Welcome to another episode of Judgment Day. We've been doing these programs over the lockdown. May well be that sooner rather than later, we'll be back to some level of normality and won't have to do them again. But so far, what we've been trying to do is try to puzzle out what the implications are, both medically, legally, and economically. And of course, we are now, as we do this particular program, in lockdown stage 2, and it's therefore tremendously fortuitous that we've managed to procure again the services of Professor Glenda Gray, who came on this program some while back and who's with us again, which is fantastic news, and we can perhaps assess where we are now. So Glenda, when we spoke last time, you were predicting something in the region of 500,000 infections, which of course your prediction has been absolutely correct, close to 600,000. I think there was mention of 40,000 deaths, and of course there's a great deal of dispute about how many deaths there are. We'll get there. But where are we now? I mean, now that we're in lockdown stage 2, does that mean in a sense the worst is past, or are we going to sort of become like other countries where within a month or two we'll be back to where we were?
Well, I think we're in the what I would call the endemic phase of this epidemic. So we've seen the surge, and we are seeing decreased death rates, and we're also seeing an easing of the hospital beds. But community transmission will continue to grumble on at a low rate. And I think the balance is to try and make sure that the community transmission doesn't escalate to a stage where we run out of bed capacity. And so it's unlikely that we're going to be able to eradicate community transmission. We've seen reports in New Zealand now. Just this morning I was reading that they had claimed that they had managed to eradicate COVID-19 from their country, and now there's reports again that there's a resurgence. So we're going to battle with trying to eradicate it. So what we have to do is try and make sure that the infections, the community transmission grumbles on, but never gets to an extent where things are out of control in the country again.
And how would we do that? I mean, or let me put it slightly differently. What are we going to do differently to everywhere else in the world, which seems to have, in a sense, I don't know if you call it a second wave or a resurgence of the first wave. I mean, you can let me know about that. But I mean, most countries seem to have essentially had the period that we've had, and then all of a sudden things start ticking up again rather dramatically. Why would that not? How can we prevent that from happening?
So what we want to do is we know we're never going to eradicate COVID-19 from our country. So I think that's the first point. The second point is how do we slow down or control transmission so that we can manage the medical admissions and the sick people that need care. And the only way we can do it is with tools that are 100 years old. Social or physical distancing, wearing a mask, washing your hands, avoiding congestion, crowds for more than 15 minutes, and also making sure that there's good ventilation in rooms, particularly schools and places that will have will have more people than you would want. And so those are our tools. And the other, and it's a weird. This is a weird epidemic, and it's a weird infection because for a lot of people, this infection is asymptomatic or mildly symptomatic, and people can manage it. But for a group of people that are old and have comorbidities, this is a devastating disease and can lead to your death. And so on the one hand, it's a mild disease, and on the other hand, it's a devastating disease. And so what we have to try and do is make sure that we don't transmit to people who will have a devastating outcome should they get infected. And so we have to implement our tools. We have to continue with the wearing of masks. They have helped because we haven't even had a flu epidemic this year, and we were worried about having a flu epidemic as well as a COVID-19 epidemic. And you can see what physical distancing, washing your hands, and wearing a mask does. It averts an epidemic of flu.
Does that mean that as we go forward, things like, for example, the restrictions on 50 people at gatherings and so forth, that's got to continue for the foreseeable future?
That's critical. you have to make sure, even if with 50 people, that there's enough space, 1.5 to 2 meters, that there's air flowing, and that people have washed their hands and are using their mask properly. You know, you must have your mask over your nose, because you can breathe out all these viral particles. So it's about correct mask use and fastidiousness to hand hygiene and distance.
So can I just then ask you, what are the probabilities? I mean, for example, speaking to some of my friends who are doctors, one of whom predicted relatively accurately, it seems, when I spoke after the interview, he agreed with you, not that he's a virologist, although he runs old age homes, but he says, well, by November, we'll be back to some serious infection rates again because people will relax their guard, because we'll have to open up tourism, et cetera, et cetera. I mean, is that really on the cards, or do you think we can smooth this out in the way we've done, rather more successfully than perhaps many people predicted, and more successfully than other countries?
Yeah, so I'm a pediatrician first and foremost, and an infectious disease person, and I aspire to be a virologist. But so just I think that what we are seeing in Europe is a resurgence of the epidemic, especially amongst 15 to 25-year-olds, because these kids are sick and tired of being at home. They also live in very crowded, congested areas, are probably in digs. They want to go to clubs and they want to go to restaurants and bars. And so we are seeing an increase in transmission in Europe in that group. And I guess we could also predict that we might see that as summer comes and people want to get out and about. And I think that we have to try and make sure that the messaging and the behavior change that we are asking for continues to be implemented. And it's a contract that we have to have with each other. I have to adhere to non-pharmaceutical interventions to protect the next person. I'm doing this to protect you, you're doing this to protect someone else. And so, I protect myself and I protect you by doing what I have to do. And if we don't watch how we open up society, we could have these resurgences. And I think in South Africa, what we hope to avert is a second wave, like you see in the United States, where you basically have an endemic epidemic, because you have such high rates of infections every day. The epidemic's out of control there, and it's out of control because, first of all, there was a reluctance to wear masks in public. They only started to use it later. They rejected the issue of crowds, crowd control and congestion, and didn't pay attention to how the epidemic seeds back into society. Food packers and paying poor attention to where seeding can happen through migrant workers, and not being mindful of certain messages that you might have to implement in certain population groups to try and avert the onward seeding of COVID-19.
Can I then ask you about the question of schooling, which of course in the States has become a very big issue as well. And there seems to be, again, it depends on who you listen to, about children being transmitters of the disease, etc. Now, as we open up schools, I mean, the universities are closed till the end of the year, and we're all teaching on Zoom. But schooling, if you open up fully, I mean, such as they're proposing in the States, the suggestion is that actually that gets a serious amount of transmission back into the community. Would that be the case here as well?
Well, I think it's a risk-benefit ratio that you have to try and balance. And what you have to try and do is contain transmission in any place. And so there's been a lot of community transmission already, and this is without the schools open. And so we can definitely say that the schools did not contribute to the first wave of the epidemic at all, just community transmission. And when the schools open, a lot of the transmission will occur because of community transmission or household transmission. And when you look at the data, if you're implementing your spatial distancing, classword transmission and transmission from scholar to teacher is can be de-risked. So it's not as if we're going to not have any infections in the school or in the classroom. And there will be infections. And the good news is, I guess, is that children are largely spared from the devastating disease that we see in elderly people. And so what we have to try and do is prevent children who may transmit, who are at low risk of transmitting, but who may transmit to teachers that have comorbidities or elderly relatives in the household. And so what we have to try and do is just make sure that if kids are symptomatic, if they are exposed, is that they go into quarantine. If they're a case, they're going into isolation, and that you manage their close contacts and their families. I think as we get used to managing COVID outbreaks in schools, we will see less and less schools closing down and less classrooms closing down. And what we hope we will see is that that the child and its close contacts, or the teacher and their close contacts, are put into isolation and quarantine, and schooling goes on. And so we're going to have to accept that we're going to have this epidemic for a long time. And so we can choose between trying to de-risk the school and trying to do education, or saying, okay, we're gonna wipe 2 years of schooling off the record and start again in 2 years' time. And that will have devastating effects on universities, training of doctors, nurses, teachers, in losing 2 years of a curriculum. We already lost a year. Even with opening up the schools now, we've devastated our school year, and I'm not too sure how kids are going to proceed and what kind of quality learning they've done this year.
I can I just ask one final question before, because you raised a whole lot of issues I do want to explore with you. When I interviewed Dr. Nick Spohr, who of course is not a virologist but an educationist and economist, he suggested that supporting the idea that the school should be open, in fact was very critical of the closing. But he did say, when I pushed him, that if the schools didn't have running water and proper toilets and so on and so forth, they should not be opened. And we do know that there are a hell of a lot of schools of that kind in South Africa. Would you agree with that?
Well, we've had since the 27th of March to what's today, the 20th of August, to address those issues of lack of water at schools and lack of portable toilets at schools. So there's been a lot of time made available to address the lack of water and sanitation at schools. If there is no water at schools, one can also make sure you saturate the school with hand sanitizers, and make sure that you address you become innovative in your ability to manage schools. So I know hand sanitizers are much more expensive than water tanks, but I think that in this period of time, our job is to try and make sure the poorest of the poor kids go to school, and they're the most vulnerable. They're the ones that actually need the education the most. And so, how do we de-risk their learning? And how do we make sure that those children in the poorest circumstances get to school and are protected in their schooling, teaching outside, maintaining distance, making sure that desks are cleaned and wiped down, and making sure that the water tanks get to the schools, because there's been enough time for that to happen.
But I mean, I obviously, I think any sane person would be absolutely 100% behind your argument that they are the people who've borne the brunt of this, and therefore we want their schools to open. But in a sense, what you are suggesting is that those are preconditions. Hopefully they've done the job, sanitizers and the rest of the stuff at their schools. But if they're not, then it would be very dangerous, I assume, for those children.
Well, I think you're going to have a negotiation with the community. You have school governing bodies, and you have communities around, and maybe the communities can bring buckets of water to the school. So there has to be a social contract. The whole community has to buy into it. They have to say, the school, we need to de-risk the school. And as a community, as parents, and as shop owners and taverns, in the area, let's bring buckets of water every day to the school. Those are innovations that there can be a contract. And so I think that we have to think of plans, how we can secure the education of a child, how do communities help, how do parents help, can we all bring a bucket of water or a liter of water to schools and donate the water to the schools so that kids can learn?
Are we, reasonably, the scientists, not people like me, but is the scientific community relatively clear now that in relation to younger people, particularly children, that the effect on them isn't particularly massive for themselves? You can understand that, there are all sorts of stuff that gets floated around about, you get exceptional kids who do get very ill. Are we fairly convinced that, in a sense, the cohort of younger people may have the infection, but are not going to be particularly badly affected by it?
Yeah, we've seen there are millions and millions of people that have got infected with COVID at a global level. And we've seen consistently, country to country, that children are less affected by it. Of course, children with severe comorbidities, children with cancer, children with congenital heart abnormalities or heart disease or cardiomyopathies, there will be children that will have an adverse outcome, but it's logarithmically, it's so much less than adults. And so I guess the question is, is that enough reason to keep kids at home? Rather find out who those children are. So if there is a child that has comorbidities, work with the family, work with the doctor, with the clinic, and the school to keep that child at home or to keep that child protected. And so it's easy to identify those children. And if parents are scared, or communities are scared, or teachers are scared of certain children being at school, then that is an individual child that you can work around. And so you have to, you can't make policy and not address the child with comorbidity. You need to identify that child and protect that child like we do with teachers, and allow the rest of the school to continue.
So can I just then move on slightly and ask you this? When we spoke last, you did mention some while back that the modeling was suggesting between 400,000 to 500,000 infections. And in fact, that has been more than that, but not, about 600,000. And one was talking about 40,000 deaths. Now, there's a lot of dispute about the 11 or 12,000 deaths. And I noticed an article in Groundup the other day, which did took Debbie Bradshaw's figures and tried to work out what it would be, and suggested it may be closer to 30,000 deaths from COVID. What is your view on the death figures?
So we do know that both in South Africa and abroad, that we grapple with the exact amount of deaths attributable to COVID-19 for lots of reasons. First of all, people might not write COVID on the death certificate. So you can't count them. They may misclassify deaths, and so they can't be counted. People may die before they get to the hospital, and you have to make a call. Then, if someone says, "Oh, this person was breathing fast," do you make a call about pneumonia, or do you make a call about COVID? So there's going to be underreporting of deaths, because people no one always dies in a hospital with a doctor who knows, who's been looking after the patient. And so there will always be underreporting of deaths, and there also will be people that will die because they're too scared to get to the hospital. I've heard of reports of people dying of a duodenal ulcer because they were just too frightened to get to the hospital because they thought they were going to get COVID. And so there will be people with TB, HIV, and other diseases that will never get to hospital because of their fear of hospitals. So the 33,000 deaths that we see that are excess deaths, as we call them, there will be some that's related to COVID, and there will be some that are collateral damage because of COVID. And I think that, we shouldn't split hairs about who's dying from what. in a epidemic. Every death in an epidemic is tragic, and it's important to try and understand and prevent the ones that are preventable. South Africa does have a lower mortality rate, and obviously it's important to discern the differences. But remember, we have a youth bulge, so we are a country with a lot of young people in, and less elderly people, and so the mortality rate will be different as compared to Italy or the UK. But remember, we also do have less hospital beds and ICU beds, and so so to try and find out exactly how many people died of what is important. But the most important thing for me is, to try and avert a preventable death in an epidemic.
Absolutely. But so let's assume, just for the purpose, you don't have to hold me to this, but even if the death rate was roughly 30,000 in total from COVID, and at roughly 600,000 infections, that means we've done pretty well in terms of the percentage mortality rate compared to many countries in the world. Far better than Britain, which has been utterly disastrous, but better than many, many other countries. Why is that? Why have we? Is it because we've got a younger population?
I think it's lots of factors. So first of all, even though
how much can we pat ourselves on the back and saying, people like yourself pat yourselves on your back, and the government saying, actually, they've done pretty well despite all the criticism. That's what I'm trying to understand.
Yeah, I think that in the beginning we didn't know the natural history of COVID-19 in South Africa or in Africa, and we also didn't know what the comorbidities of HIV and TB would do, all the issues of obesity, hypertension, and diabetes. And so we have seen a different profile or different demographics in death in different provinces, and we have seen an earlier death rate in younger people who are in their 50s who have comorbidities like obesity, maybe more so than in the US or the UK. But we certainly have been able to manage the deaths and the hospitalizations quite well. So I think it's an interplay between a younger population, our youth bulge, and less elderly people. And but at the same time, we do see a huge burden of adverse events and deaths in 50-year-olds that were surprising to us. A lot of doctors that we work with who are in their 50s, who have comorbidities, have died from this disease. So so I think we've done well on some level, and that's because of our demographics. But it's also been devastating for younger people with comorbidities, people who are above 50. We've seen terrible outcomes for our doctors who obviously, there's a combination. So the more, there's obviously your genetic risk factor, there's your comorbidities, there's the amount of virus you're exposed to and your viral load, and there's a whole interplay between, and then it's also the timing, recognizing when you're ill. A lot of people may not recognize that they're ill, and you suddenly decompensate. So it's also about education, making sure people get to hospitals early. So I do think that our mortality rate is lower, definitely lower than the UK, but not as low as we think it is in South Africa. I don't believe it's 1.8%.
Yes.
I would think it's around about 5%.
Oh, wow. Okay. But then let me ask you this, just again, from the point of view of utter ignorance, which means I represent all sorts of people who just don't know. That you mentioned the viral load. Does that explain why it is that you hear, extraordinary stories of people sort of getting COVID and dying, and others almost of the same profile, shrugging it off with a mild dose of flu? Does it depend to a large degree on the extent to which you've been exposed? Does that explain something?
I think exposure is an important it's an important factor in disease progression. It's not the only factor, but I do think there's a relationship between viral exposure, the amount of virus you have in your body, and the progression of disease. So that is a feature, I believe, it will play a part. But also, obviously, if you are obese and have other comorbidities, you may not need that much exposure to make you progress. I think it's an important factor, but not the only factor.
So you've mentioned quite often on our conversation the fact it's going to be with us for a long time, which brings us conveniently to the question of a vaccine. So what is the deal here with a vaccine? I mean, everybody's placing, well, everybody, I think ordinary people like myself are placing a huge amount of store that we'll get a vaccine, and maybe not back to absolute normal, but to a much more relaxed scenario than we've got at present. What is the foreseeability with regard, one, to a vaccine, and two, what the effect of the vaccine would be?
So I think there are two things that we wish for when you want to eliminate a viral disease. One, you want a vaccine, or two, you want an immune response from natural infection that confers long-lasting immunity, so you can have herd immunity and protect the people that didn't get exposed. So there are two things that we need with this. We do need a vaccine, and we also need good herd immunity. And there are reports coming out now that they are good in us, even though your antibodies seem to wane over time. There's good memory T cell responses and good CD4 and CD8 T cell responses that confer long-lasting protection. So that's good news. The other thing is the race to find a COVID vaccine. And what I do hope is that there are going to be lots and lots of different strategies that are all going to be successful, and that we need 5 or 6 vaccines to work to make sure that at a global level there's equity in distribution and there's affordability. And so I think that it's important for us to, it's hopeful that hopefully that there'll be more than one vaccine that's successful. Because if only one vaccine is successful, then we're in big trouble, because it's going to be very hard to get those billions of doses that's required. And I do think that there's good plausibility that one of these vaccines will work, or hopefully more. We have the non-human primate model that shows protection. And if we do see good T cell and good T cell responses that confer immunity in normal natural infection, then we're lucky for a COVID vaccine. So I think that given that, I think we should have a vaccine readout by January, February next year. And then it obviously takes longer to get a vaccine registered. But I'm hoping that we have a signal or a readout by one of these vaccines by January or February next year.
And let's assume we do get that. Let's assume that they are successful. Then how long does it sort of take? For example, I assume that you've got to be prioritized. So health workers would be entitled to vaccines, presumably before anybody else, quite rightly. And then you'd want to get that population that you're talking about, who are more vulnerable, to have a vaccine. If, for example, by next year, late next year, that's the case, does that mean, although it'll be with us for a long time, that in fact life would then become a lot more, if I could use the word, normal?
Yeah, I think a combination of herd immunity and prioritizing certain groups to get the vaccine will help control the epidemic. And so I do agree that healthcare workers or frontline workers, anyone who's interfacing with the public, teachers, nurses, doctors, people at home affairs, tellers at shops, anyone, taxi drivers, definitely taxi drivers and taxi commuters, should be beneficiaries of a vaccine, and then together with a long-lasting immunity, then hopefully that's the best way to control the epidemic. So I do think the combination of a vaccine and hopefully long-lasting immune responses from natural infection will help control or contain the epidemic, so that we can go back to a normal life, if we ever remember what that is.
Yeah, I agree. It's hard to remember. But can I then just ask you on that, the fact that we, South Africa, are participating, I think, at the Oxford trial, as I understand it, does that mean that if that vaccine is successful, that we will have some entitlement to that vaccine rather quicker than otherwise might be the case?
We will be enrolling into 3 different trials, by mid-September. So we have the Oxford chimp ad study. We have the Novavax study that's starting in now, and then an A26 J&J study that's starting in September. And so I think we're going to there'll be 3 different strategies to get access. One will be a direct relationship with the pharmaceutical company, and certainly J&J with A26 has said that they would make a vaccine available for not at profit during the pandemic, and so that they don't want to make a profit out of it during the pandemic. And there are other financing schemes. There's the WHO process where there's a global financing mechanism, and then I guess there's bilateral agreements between governments, between China and South Africa, the US and South Africa, Russia and South Africa. So depending on how how the data looks from all these vaccine trials. So I think there are going to be different mechanisms, global financing mechanisms. But what we obviously have to show is equity in South Africa, and actually equity, immunization equity or vaccine equity in the SADC countries. South Africa is lucky because we are enrolled in vaccine trials. We have a sophisticated regulatory authority. We're able to license vaccines and drugs fairly quickly. And we're going to have to see how we help other countries in Africa, get access to vaccines. And maybe we need to think of an African bloc or an AU bloc, or a BRICS bloc that works together to get vaccines for its region or for its sector.
So if I just track your timeline for a moment, and assuming that you get your rollout by January or February, and it is clear that in fact there is a vaccine, or more preferably vaccines that are going to work, what does that then mean in terms of, let's say, the ordinary South African's lifestyle between now and, let us say, the next year? That means we're going to be living with quite a considerable amount of restrictions for that period, because on the line of argument that we were talking about earlier, we don't want to have another outbreak or two. So does that then mean we are going to be living with a series of restrictions for some while to come yet?
Yeah, I can't see us, as long as there's community transmission and people are getting ill, and I can't see us going back to the lifestyle that we had before, and until this epidemic is under control. And so if there's a readout of a vaccine in January, February, it'll still take us till July, August, or September to register. If there's a fast track registration, or if we use a certain mission, we still will have to, bulk buy the vaccines, and these vaccines still also have to be made. And so, our pharmaceutical companies are obviously hopeful that their vaccine is going to work, but are they making billions of doses at risk? When do they trigger their production? And so, if you're a drug company and you're making a vaccine and you hope it's going to work, and you have to invest in making it. And so, when do you time making your billions and billions of doses, or do you get some kind of financing scheme that the public purse, bankrolls the risk?
Yeah.
What do we do at the moment? Because we do need the vaccines quickly, and do we how do we finance? But if we don't want to be behind,
would we be relying on importing the vaccine, or would we be able to make the vaccine?
At the moment, depends. I guess it depends on the platform. So it depends on whether we're able to do tech transfer on viral vectors. And if the vaccine is maybe an inactivated vaccine, or a vaccine that just looks at RNA, it's probably easier to do tech transfer and fill and finish and production in South Africa. But if it is a viral platform, we would have to invest greatly in a different kind of biological process, which is not implausible, but would need expansion of our capabilities in South Africa. And so we are, BioVac can do fill and finish, and we are talking to BioVac and other biologicals in South Africa to see whether we can expand vaccine platform to accommodate different kinds of vaccine approaches. But you need different manufacturing capabilities. You need bioreactors, and you need a whole lot of different processes depending on which vaccine approach that you use. But certainly for certain vaccines, South Africa could do the fill and finish and distribute locally.
So then finally, just on this, so what you're really saying is that those of us listening to you are not going to be hopping on planes and going overseas for some while yet. I mean, we're going to be living in a restricted environment for quite some while.
Well, I think you're going to have to do your risk-benefit decisions about travel. So at this moment in time, international travel is not allowed. And towards the end of the year, I guess the country's going to have to think about the tourist season and how we manage inbound tourists and how we manage the economy, particularly those people who depend on tourists. And so we're going to have plans in place to bring tourists into the country, but to also de-risk the industry and de-risk because we don't want a tourist to die from COVID in South Africa, and we don't want a tourist to seed the second surge in South Africa. But we do need tourists, and we do need to open up that industry. And so, like schools and like other parts of the economy, we have to find a way of generating money and minimizing or de-risking the environment.
An extraordinary, I'm running out of time, so there are many issues that I'd like to discuss with you, but I suspect we can have you back in about 2 months' time to assess where we are. But Glenda Gray, thank you so much. It's been very valuable. I'm not quite sure whether I should be jumping with glee or slitting my wrists in relation to where we are, but thanks so much for your time and for the efforts that you've made on behalf of the country. Thank you.
Thank you very much.